Hello, this is Joe Trahan, welcoming you to the All Me podcast from the Taylor Hooten Foundation, whose mission is to enlighten the world to the truths about appearance and performance-enhancing substances. As the national leader on this subject, they communicate their educational messages through various methods, including this podcast. Thank you for listening and enjoy the show.
Hi, and welcome to the All Me podcast. My name is Tavis Piatoli, and today I'm going to be your host. In 2022, nearly 1 in 3 men and 1 in 4 women were considered overweight, with more than 42% of adults being considered obese. The global weight loss and weight management industry has a market size valued around $224 billion, and it is expected to surpass $405 billion by 2030. What's alarming is over 90% of people who invest in a weight loss program usually regain all of their weight back at some point. On December 23rd, 2022, the drug Semaglutide received FDA approval to be used as a weight loss medicine for those 12 and up who have a BMI over the 95th percentile. How effective are these types of drugs? And what are the potential side effects and risk? In this episode, we speak with Dr. Robert Driver about the mechanisms of action around these drugs, the potential side effects and risk, what type of weight is someone losing from their use, are they suitable for children, and much more. But stay tuned until the end for the curveball round to learn what would be the one drug he could invent to change the landscape of health. Dr. Driver is a board-certified emergency medicine physician who has been practicing medicine for over 20 years. He is certified in advanced bioidentical hormone replacement therapy and is also a member of the Age Management Medical Group. He received his Bachelor's of Science in Business Administration from Duquesne University and his Doctor of Medicine from Drexel University College of Medicine. He founded Spartan Medical Associates. As his opinion of aging and health evolved during his professional career, he noticed a lack of focus on proactive medicine and was frustrated with the failings of standard medical treatments. He also learned to reject the notion that some things just come with old age. Fatigue, weight gain, muscle atrophy, osteoporosis, and other old age symptoms can be prevented and reversed. Dr. Driver has become an expert on hormone replacement therapy and wants to help clients restore balance for a healthier life. He also offers individualized bioidentical hormone replacement strategies and a concierge level of service that brings the expertise to you. Dr. Driver, thank you for joining us today at the All Me podcast. How are you?
Hi, Tavis. Good morning. I'm excited to be here with you. Thank you for making some time for me.
So this is going to be a phenomenal topic because, as we kind of discussed, I polled some friends, I polled, social media to say, what kind of questions about weight loss drugs, especially I know we're going to talk about Semaglutide and a lot of the experience you have. So this is really going to hopefully solve a lot of issues with people that are either using these drugs, considering to use these type of medicines and see what it could do. So I'm excited. But before we really dive in to the topic, I always like to learn about the actual guest. So tell me a little bit about your career path as a physician. What interested you in wanting to become a doctor and just, choose the specialty that you're in now?
Okay, sure. So it's kind of interesting. So medicine was a second career for me, actually. I had gone to college and studied business and then, left and went into the business world and was there for a few years. And it really wasn't what I was after. It wasn't what I was interested in. It really didn't fulfill me. And I realized that I wanted something science-based. I enjoy the scientific process. I enjoy discovery and learning. And then I wanted something that dealt with people. I enjoy interacting with people. I enjoy helping people. I enjoy, making people's lives a little bit better in some way. And so, went back to school, went to medical school, completed that, then did my residency. And I'm trained in emergency medicine and have practiced emergency medicine for 23 years now. And then getting into where I am now, that was also kind of a second career. It was a second phase of medicine. My own health, I was doing all the things I thought I knew to be healthy and fit and active, but wasn't feeling great in my early and mid 40s. And so then started my own practice dealing with, health and fitness and longevity and wellness and quality of life and focusing on different aspects of medicine than I was used to treating in the emergency room. And so I've been doing that as well for about the past 10 years.
Yeah, it's amazing how we work in certain medical, I guess, professions. And a lot of times our work is so overwhelming, we can't take care of ourselves. And then we realize, okay, we're in our 40s and we got to start taking care of ourselves, right? If we're taking care of other people. And I've been in that same boat as well as a dietitian. It's like people think you got to look like this and you're supposed to feel like this and know all this stuff. And it's like, well, realistically, it sometimes becomes a little difficult to do that. So it's good to kind of explain your background. Do you see patients, before we get in our topic, do you see a lot of patients that come to you for weight loss?
So our practice, again, we have a wide variety of things that we treat in our practice. One of them is weight loss. Our practice primarily focused at its start around hormone replacement, and that is a great tool, for health and longevity and preventing, kind of diseases of frailty. But weight loss is something else that a lot of patients struggle with. A lot of people in general just struggle with weight control.
So let's talk about medicines. Let's dive into this topic. What are some of the most commonly used weight loss drugs that are being prescribed by physicians currently?
So, we'll get to semaglutide, which is the one that's on everybody's mind. But, there are a few other diet medications or medications used for weight loss. And it's funny because, everybody wants an easy button, right? Everybody wants, the magic thing that's going to just make them drop pounds and it's going to be easy. But they all work through a similar mechanism. I don't know how much is prescribed anymore, but there's a medicine called orlistat that would block absorption of fat in your diet, thereby decreasing the amount of calories you're absorbing, decreasing the amount of calories you're taking in hopes that it would make you lose weight. Side effect of that would, of course, be, you can have diarrhea because you're basically, if you're eating a lot of fat, you're not absorbing it, it's going to run right through you. There's other medications that have been out there that are stimulant based. Phentermine is still around. Phentermine is a stimulant. Again, it's an appetite suppressant. So there's no magic in how it works. It makes you eat less. You don't have much of an appetite. So decreased calories in hopefully leads to weight loss. There's another medicine out there. I'm not even sure how it's pronounced. Kismia. It's like Qsymia. It's a combination medication, which is a good pharmaceutical practice of taking two old medications, combining them together and calling it something new. But that's phentermine, so the stimulant, appetite suppressant, and then a medicine called topiramate or Topamax. Topamax was an anti-seizure medication. It's also used in migraine prevention. Well, one of the things that they found in some patients who took Topamax is they lost weight. Now, why did they lose weight? Well, if I recall correctly, it has a bit of an appetite suppressant effect. And then I think it also changed how you tasted food. So we're using a medication side effect to try and cause some weight loss just by decreasing calorie intake.
Yeah, it's interesting to see the different mechanisms of how these work. I've had friends that told me about their experience with phentermine and blood pressure, and they had to monitor that, heart rate elevated, palpitations. It's like, wow, that seems a little risky to take something that could potentially cause a stroke or maybe a heart attack just to lose some weight. But I definitely understand people want to do things to improve their quality of life. So you mentioned semaglutide, and that's kind of where we're going to start our next series of questions. And this just seems to be a pretty incredibly popular drug right now. So let's discuss this first, and let's explain a little bit about what this drug is.
Okay. So again, this is it is now used as a weight loss medication, but again, wasn't made for weight loss. It was designed as a diabetes drug. One of the side effects, one of the things that happened to a lot of people that took it was they lost weight. So it was basically rebranded after an additional study to get FDA approval as a weight loss medication as well. So let's go back and look at it from the diabetes perspective, since that's where it was originally formulated, or it was originally designed. So type 2 diabetes at its core is high blood sugar secondary to insulin resistance. So in order to lower blood sugar, we need to usually do two things. We need to increase insulin secretion and or decrease glucagon secretion. So in our body, we have a hormone called GLP-1, glucagon-like peptide, and it's secreted by your gut. This medication, semaglutide, mimics the effects of glucagon-like peptide. So it mimics the effects of GLP-1. So when this medication is administered, it increases production and secretion of insulin, again, in a diabetic patient to lower their blood sugar. And then it also decreases secretion of glucagon. Now, how does this play into weight loss? Well, it seems that it has, GLP-1 activation has some central mechanism as far as appetite suppressant. You don't want to eat as much. And then it also affects your gut in how your gut responds to food. One of the things it does is like delay gastric emptying, so you feel full longer. So it works, again, it's a side effect of a medication that we're using for weight loss, but the mechanism by which weight loss comes about is really appetite suppression, decreased calorie intake.
Yeah, that makes sense, right? If we eat less, we should see the scale move.
We should see
right?
some weight loss.
Yeah, and that's what people want, right? We're going to talk about some other things related to weight loss in a second, but yeah, weight loss is a big driver and a big motivation for a lot of people to say, all right, I'm motivated now. Once they see a couple of things working and moving, then they get really fired up and they want to keep that going. So you talked about why this drug was a good candidate and what are the mechanisms. What about the dosing for this? So how does dosing work? Does everyone take a similar dose? I have a friend that, and is it an injection? Is the dosing based on the body weight of the individual? Can you explain that just a little bit?
Sure. So the way it is typically administered is a subcutaneous injection. It is given once a week, and it starts at a low dose. You do a low dose, let's say 0.5 milligrams once a week for 1 month, and then you increase the dose for the next 4 weeks, again, once a week, and so forth. And the reason for the escalating dose is to keep the side effects, basically nausea, vomiting, diarrhea, under control. If you just started out at the higher dose, the side effects would probably be too much and no one would be able to continue with it. So it's ramped up slowly. And when used for weight loss, the way we instruct our patients is once we get to a dose where they're having success, their side effects are minimal, and they are having weight loss, then that's where we'll stop. And we stay at that dose until they've lost the weight that they're looking to lose.
Excellent. Okay. Now let's talk about the length of time. You mentioned, I guess this kind of, you've already answered my next question is how long should someone use this medication? Because do we stop once they hit that specific body weight goal and you say, all right, now you're at a good, and again, I don't like to use the word healthy much, but I know we look at BMI, but it's like we kind of say, all right, the person comes in and says, doc, I want to get to this weight, or if it's a realistic weight, do we stop them once we get to that weight, or is it a short term, like 3 months, 6 months, or really just depends on, I guess, the weight of that individual?
Right. So it really depends on how much weight the individual wants to lose. But with that, I will say that, the first 12 weeks, the first 3 months is really just a ramp up phase. So you're probably not going to have a tremendous amount of weight loss in the first 3 months. So this is, I don't recommend this medication to someone who wants to lose 5 or 10 pounds. Through a good nutrition strategy, losing 1 pound a week is a very reasonable goal for most people. And if you're going to take 12 weeks to, even start getting up to speed on this medication, you could, theoretically lose 5 to 10 pounds without it. So I don't recommend it for people who are just trying to, lose a couple pounds before summer gets here.
Yeah, and that's, I mean, you're like, I love it that you're getting kind of answering some of these questions before I get to ask them, because my next
Sure.
question,
Sorry.
no, I love it. It's great, because my next question was kind of like, when does this type of drug get discussed with someone? Is it at a specific body weight, a BMI, and where they can qualify for this? But you really answered that, is like, all right, if you're just looking to lose 5, 10, even maybe 15 pounds, let's change your habits and get you to maybe look at one or two dietary modifications that you can make, and maybe incorporate something in your your
Right.
day that's going to help you burn more. Whereas if someone is 50, 100, 150 pounds over where maybe they should be, then it's probably an area that needs to
Right.
be discussed with them.
Exactly. And to go back to one of the points that you were asking in the last question, how long are people on it? Usually it's more of a longer term therapy. A year, is pretty typical.
Okay.
But again, they do need to lose a significant amount of weight. So
let's move to like the age appropriateness. A couple of questions I received was, college freshmen are asking about this. And then I had a friend that said, what about my 13-year-old who is, struggling right now with being overweight? And is this an area where you look at the person's age and go, there's no way we're doing this for kids, and et cetera, et cetera?
Right. And so this is a very important point. And it's important for adults as well. Yes, this is an effective medication. It's probably one of the most effective weight loss medications. But again, there is no magic behind it. It's decreased calorie intake. How tightly controlled is a diet? What have we done before? What are the other measures that someone has used? I would be very hesitant to start a child on a medication like this. Keep in mind, adults, and it's being studied, or it's been studied in kids, and it's going to be recommended for adolescents or older kids. It's a tool, and a tool only. So I would be very hesitant to start it in kids. Are there kids out there with severe weight trouble? Yeah. Could it be beneficial for them? Yeah. But it has to be in the framework of changing their relationship with food and exercise.
I love that, because, that would be my answer to that, to those parents, is like, let's look at what your child is eating and see, are they eating fast food 3 or 4 days a week? Are they drinking calorie laden sodas? And we realize there's some things you can control with teenagers, and when they're away from home, you can't control besides modeling that good behavior. So
Right.
That's a great point, is can we instill the habits in them first before we just say, here's a pill? Because they're going to think maybe that pill is something that drug is something they're just going to rely on every single time.
Correct. And if if this is your only mechanism to control your weight, well, do you want to stay on this forever? Rather than using it as an intermediary tool to maybe redefine your own relationship with food, help you lose this weight while you're changing some behavior, and getting understanding, and et cetera, like you said, getting motivation, changing your activity patterns. That's great. But yeah, this shouldn't be the only tool in your toolkit, and then to stay on it, for years and years and years.
Yeah, no, that's a great recommendation. Now, for those considering this and they want to know, all right, if I really need this type of help from a financial perspective, is this covered by insurance, or does it require someone to pay out of pocket, or does it depend on the type of insurance they have?
So it typically depends on your insurance, and insurance, that can be a very broad brush of things they'll cover. But usually, if your BMI was greater than 30, a lot of people will cover it. A lot of insurance will cover it. If your BMI, I think, was 27, but you had a comorbidity that was associated with obesity, your insurance may cover it. Again, if you're type 2 diabetic, your insurance may cover it, just from the diabetes point of view. Otherwise, then after that, people are paying out of pocket, and the price for out of pocket can vary quite a lot based on who, the clinic that you're seeing. But, a few $100s a month usually is the minimum.
Gotcha. Okay. So that's good to know. A couple $100 a month. If you don't have insurance and you're like, hey, I really need this. This could be life-changing to reduce their risk for cardiovascular disease, hypertension, et cetera. It may be worth that investment to make that, decision to move forward with that type of drug.
Mm-hmm.
So my next question, you really answered, because I was curious about what about those that are not diabetic or insulin resistant and just want to lose a couple of pounds. We said that's probably not a good idea. Let's shift that. But I had some friends that asked, more about, if I'm not diabetic and I use this drug, how do I wean off? Is this something where, do you find, or maybe we don't know yet, but do people have trouble weaning off of this type of drug and say, I really need it more? Is there any type of addictive behaviors where they feel like they have to use it? Anything along those lines?
Right. That's a great question. And so, let's, thinking back to the beginning, when we were talking about other medications, that was one of the problems with phentermine. Some people, phentermine is stimulant based. There was if you were on it for a while, there was definitely seemed to be a withdrawal picture for phentermine, and that's one that could be more habit forming. I haven't seen that so much with semaglutide as far as it being habit forming or a dependence. So let's think about its mechanism of action. It ruins your appetite and makes you nauseous. That's usually not a feeling that you're going to get addicted to. So as far as, I don't see someone needing to wean off it typically. They can usually stop without significant side effect, but have they changed their understanding of nutrition while using this tool? If not, the famous saying, we're not going to solve this problem doing the same things that caused it, right? If I go back to my, pre-medication nutrition plan, which may just be eat whatever I want, the patients will eventually gain their weight back.
That's a great point. And that's something I have something coming up along those lines about changing the diet. So we're going to save that point about regaining that weight back in just a second, because I want to move to, I think, probably the bulk of what we want to cover, the side effect part, right? Because we talked about what it does and what it is and the effects of that. But a lot of the questions that I've learned about is, what are the side effects of this medicine? All medicines have things we have to be concerned. And what are you seeing as the primary side effect that we need to be concerned about with this type of drug?
So it's interesting because I've seen, so the primary side effect is GI symptoms: nausea, vomiting, diarrhea, bloating. Some people get constipation. There is a reported increase in pancreatitis. I don't think that's a very high proportion. It is an increased risk factor. However, again, patients that are more likely to use this medication are at higher risk of pancreatitis and biliary disease in the first place. I have seen some patients, I still work as an emergency physician sometimes. I have seen people in the emergency department, and they're coming in feeling, worn out, run down. They've had some, diarrhea going on now for several weeks. And, when eventually we kind of get through, well, what medications are you on? Semaglutide is sometimes the offending agent. They don't have much nausea or vomiting, but they've had diarrhea. And, we've seen people come in with basically acute kidney injury secondary to dehydration from ongoing GI losses from diarrhea. So that's again, the side effect profile is primarily a GI side effect profile.
Yeah, and that's pretty significant because, the last thing you want is anything to impact your gut, right? If you're nauseous, if you're vomiting, that's also going to prevent you from wanting to eat as well. So that's a pretty significant side effect when you look at that overall.
Exactly. Now, and so just on that topic, or on that point, if the primary mechanism by which this works is central appetite suppression, maybe we have some GI side effects like nausea. If the only foods that I can tolerate are, I'm going to go out on a limb here. If the only food I can tolerate is ice cream, well, this is probably not going to be a very effective plan for me.
Yeah. And that's some people might like that, but then
sure.
Ideal overall from a nutrient standpoint. Now, one of the things I've seen is a pretty big side effect, and it's pretty, when you're looking at losing weight, people don't understand the scale number doesn't tell you three things. It doesn't tell you fat, water, muscle. One big side effect I've seen and read seems to be muscle loss. So I know we don't want to do that, is in What have you seen in regards to the literature, at least from a muscle loss perspective?
Right. Great question. This is a very important point. When the medication was studied as a weight loss medication, they used weight as the metric. They did not look at body composition. So when people are having rapid weight loss, if a high proportion of that is lean tissue, muscle mass, connective tissue even, that is not necessarily making them healthier. If you need to lose 50 pounds and you lose 40 pounds of body fat and 10 pounds of lean mass, well, that's probably okay. But if you need to lose 20 pounds and you lose 10 pounds of lean mass and 10 pounds of body fat, that's probably not a great ratio. Or even worse, if you lost more lean mass than body fat, again, that would be detrimental. And in effect, your body fat percentage would be higher at the end. So when it was studied, they only measured weight loss. I would love to see a head-to-head trial of semaglutide for weight loss with a calorie and nutrient matched cohort to see if weight loss was different. Was there a different amount of weight loss? And was that quality of weight loss any different? Did you lose more body fat, less body fat, more lean mass, less lean mass than just caloric restriction?
That would be fantastic, because the question I had was, is this due to lack of exercise, insufficient calorie intake, side effect of the drug? If I look at this and based on what you're telling me, the mechanisms, it's the fact that they're not consuming enough calories, especially if they are, 200 pounds, 250, and let's say they're only consuming 1,000 calories a day and protein's low. They're just consuming a lot of muscle tissue with that scale weight loss.
Exactly. And so if you look at anybody who's trying to lose weight, and we'll go to a bodybuilder, right? When a bodybuilder is on a cut, they're going to lose some lean tissue as well as body fat. But what they do, and what we recommend all our patients do if you're on semaglutide, is make sure you are getting protein intake. If you're only eating 1,000 calories of food, because your appetite is so suppressed and you're having good weight loss, a good portion of that food intake needs to be protein to help maintain lean tissue. And then you should also be engaging in resistance training while you're on the medication. We could discuss the benefits of resistance training in general, whether you need to lose weight, not lose weight, on medication, not on a medication. But definitely, if you're on a medication like semaglutide, where it is suppressing your appetite and you are at increased risk of lean tissue loss, you definitely need to pay attention to your total protein intake and then engage in resistance training to prevent that, minimize
those
that.
are critical to obviously prevent that sarcopenia. And one of the things I've encouraged people to do is, look, go get a body fat test, get a DEXA, get a bod pod. Don't use a scale at home. If you go to a skin fold, make sure someone's got hundreds of tests behind their back, or using an in-body analyzer that's very reliable, that can get you some lean muscle data. That way, 3 months, 6 months later, you can look at it and say, all right, what did I lose? And like you said, if they lost 40, 50% of their muscle, it's like, that's a problem.
Right. And you make a good point. Use some type of measurement. There's a lot of ways to do it. You could do, a DEXA is great. A bod pod is great. Things get less and less precise, but are still better than no measurement, right? If you've got somebody that's going to do skin fold calipers and they've done it a bunch and they're pretty good with it, great, use that. But use body measurements as well. Definitely use more than one thing, the scale, to see how you're progressing.
Excellent. Now, you mentioned pancreatitis. So what about anything on the liver or kidney? Is there any side effects looking at those markers?
So let me see. There is stated an increased risk of pancreatitis. So that is definitely something to be aware of. Again, patients that are overweight, so that may be more likely to use this medication, are at an increased risk of developing biliary disease, gallstones, and therefore that is a very common cause of pancreatitis. So, in the original studies, tough to say, is it a confounder, but it is definitely something to be aware of. There are issues, or there can be issues with some kidney injury. However, I think that again is more likely due to dehydration and low nutrient intake. It's more probably from the side effects, nausea, vomiting, diarrhea, rather than the medication itself.
Excellent. Now, one of the questions too that was brought up about menstrual cycle. Is there any impact on menstrual cycle? One person mentioned that their cycles now, once they started, are incredibly frequent and more present than they've ever had before. Is there any relationship there that you're aware of?
That is an interesting question. I haven't heard that one before. When you ask that, my initial question goes to, or my initial thought goes to, does maybe the person have polycystic ovarian syndrome? And could there be something there where we're getting hormonal disruption? And again, is it more secondary to the weight loss versus secondary to the medication itself versus what's their nutrition intake while they're on it? That's a great question. I haven't heard that one specifically, but that's kind of one of the nuances, maybe just in weight loss in certain people.
Now, what about thyroid function? Would there be any impact on this with long-term use, especially if someone loses a significant amount of weight or just doesn't eat a lot of calories?
Okay, good question. So I believe it was in the animal studies, there was an increased risk of what's called medullary thyroid cancer. I don't think that transferred over to the human studies, but anybody who has a personal or family history of thyroid cancer should not use this medication just for that reason. There should not be a direct effect on the thyroid, but with any weight loss from any strategy, really, you're going to see a decrease in your total energy expenditure. If you were starting, let's just say, an isocaloric value of 2,000 calories a day, and you lost some weight, your new total daily energy expenditure may be down to 1,900 calories, and that just comes from some weight loss. Our body does have a built-in mechanism to try and defend a set point, so it can take time to adjust to a new body weight. So to answer the question specifically, I don't know of a direct effect on the thyroid. There is the caution with that family history of thyroid cancer that they should probably not use this medicine, or could be at increased risk with this medicine. But from a micronutrient point of view, again, depending on what you're taking in, could you develop some thyroid dysfunction because of poor nutrient intake? That's possible. But again, would be more to a nutrient intake issue rather than the medication itself.
Awesome. Thank you for that explanation. Now, last question about side effects. Do we have any literature on the long-term side effects yet, or is it just too soon to know, what's going to happen long-term?
I think it's probably too soon to know. And, it's been used more as a diabetes medication and less amount of time as just a pure weight loss medication for non-diabetics. So I think it's too early to know. Again, my biggest concern is things like the lean tissue loss. I would love to know head to head, how does this medication compare to just nutrition and exercise intervention, dietary restriction of some kind? Do you have an improved rate of fat loss? Do you have a worse rate of fat loss? Increased lean tissue loss? That's something I would love to know. Hopefully we get a better signal on that with continued use, and hopefully it doesn't turn out to be more detrimental.
So for any graduate students out there listening, if you're thinking about a topic for your PhD dissertation, this is a great opportunity to take what Dr. Driver mentioned and create a study looking at those.
That would be a wonderful study. I think the hardest part would be getting funding. I'm sure the drug manufacturers do not want to run a study that might show their medication has a worse side effect profile.
Yes, that is true, right?
That would worse outcome.
A lot of money loss.
Yeah, exactly.
All right, we've talked about the negative side effects. So I know obviously the positive outcome of this is weight loss, but outside of weight loss, any other positive effects that maybe this drug can have on someone?
I don't think so. Again, so let's go back to how is it working, right? It's working. We're basically using a side effect of a diabetes medication. We're using a side effect to help curb calorie intake. So I don't think it's going to end up having any other long-term benefits other than weight loss. GLP-1 has a lot of activity in the body. Could there be a case made for, like a low dose semaglutide that's not aimed at weight loss, that's, going to have beneficial effects somewhere else? Maybe. Feels a little roundabout way to get there, though.
Yeah, no, and I guess the only thing would be you lose weight, probably reduce your risk for disease, but you have to lose weight first. That's going to be
correct. Correct. Yeah, that's going to, I was thinking more of it. Are there going to be benefits outside of the weight loss realm?
Yeah.
I can't imagine. So, anything's possible, but I think, yes, the primary thing is going to be weight loss. Hopefully, even if someone's not diabetic, they very well could have some underlying insulin resistance. Improving the insulin resistance is definitely going to be beneficial for decreasing downstream comorbidities and increasing downstream health.
Now, usually when you start new medications for certain types of things, like with statins, you want to measure cholesterol changes of certain markers. With this type of medication, should blood work be monitored once starting this drug? And if so, what markers would you be monitoring and how often?
So you should at least start with, a picture of what's your underlying health. What are your liver functions to begin with? What's your hemoglobin A1C to begin with? If you could understand what's your fasting insulin to begin with, that would be terrific. And then monitor along the way for either complications such as kidney injury, which can happen. And then also you can also use it in a way to monitor progress. To see an improvement in hemoglobin A1C that's been shown to be very effective in diabetics. A decrease in fasting insulin could also be a better or earlier biomarker of improvement. And then let's see, I think those are probably the main ones. And then as far as frequency, depending on our starting issues, probably 3 to 6 months. Every 6 months would probably be good, if you're having significant side effects of GI losses, vomiting and diarrhea. I would keep a closer watch on your kidney function.
And I guess you kind of answered my next question. So I was like, is there a point where you would advise someone to stop using if you saw some sort of significant change in their blood work? And I guess that would be kidney function or something along those lines.
Those would be two. And then the other one, I haven't seen it in any of our patients. I have had friends and colleagues discuss this with me, and they've had friends who are like, oh, I'm taking this medication and I am so weak. I'm so tired. I'm so weak. So maybe you should back off that medicine a little bit. And I think a lot of that was just due to they're eating almost nothing and very little protein intake and not exercising. So that's more of just a wasting syndrome. Yeah.
Got it. Now, one of the questions I got from a friend was, there's a drug called Ribelsis in tablet form. Do you know how this compares to semaglutide injection in regards to effectiveness, cost, and side effects?
Yeah, so it is the same medication. It is semaglutide, but it is just as an oral form. I've never used it with patients. My understanding it is less potent. We do have patients who get good weight loss on a lower dose. You don't necessarily need to be at full dose to get weight loss. Anything that's going to help curb the appetite, help you move along, help you move forward with an improved nutrition plan, and so maybe some increased exercise, and like we talked about, resistance training to prevent lean tissue loss. The oral tablet Ribelsis may be effective for you. My understanding is that it's not quite as potent at the higher doses. Cost-wise, I don't know. I would imagine similar.
Excellent. As we kind of get towards the end, we're going to shift a little bit about the drug, but more about the outcome and habit change. One of my concerns with drugs like this, it doesn't really teach someone how to eat or change their habits, which in turn could cause them to gain all the weight back if they haven't learned how to eat properly once they stop. So my question really around this is, have you seen any cases like this in your practice when someone stopped using the medicine, they went back to their lifestyle and called you back and said, Doc, I need to get back on it because I gained all my weight back?
Yeah, absolutely. And that is a key point. And this, when you look at the studies in the diabetic patients where it started, then when you look at the studies that were done from a weight loss perspective, because they were monitored, how long did people keep weight off? A lot of people did keep weight off for a while, but yeah, if you went back to your initial nutrition strategy, you will eventually gain the weight back. It might take a year, it might take a little bit of time, but it's basically the same as any other fad diet at that point. You're decreasing your calorie intake, you're decreasing your total energy expenditure, you're losing some weight. But if along the way you're not learning a new way to do things, the weight's going to come back on.
Yeah.
And we talk with patients at the beginning about that. And I think that's part of responsible prescribing. I get more than a little frustrated with websites who say, no need to exercise, no silly diet, just take this medication. That's bad medicine. That's bad advice. And I have a problem with that. So we talk to people up front. People will ask, hey, should I take this? Well, we start with, how much weight do you need to lose? If their goal is 10 pounds, no, this isn't the way to get there. If their goal is higher, this is a tool, but it has to be part of a comprehensive program of understanding what their nutritional strategy should be. And there's a lot of ways to do that. There's a lot of ways to eat well. I am diet agnostic. We need to find a nutrition strategy that you can be consistent with. And again, consistency does not mean perfection. Eating well most days is what gets you there. Focus on protein intake, total calorie intake. What's the makeup of the rest? That can be flexible. If a person loves to eat paleo, great. If they want to do Mediterranean, great. If they want to do time restricted eating, great. If that's a strategy that allows you to optimize your protein intake and control your total calorie intake, then perfect. Then this is something that can work long term.
I love what you said there. So many different great points: consistency, not being obsessed with perfection, trying to find what works for you. Those are all things I've tried to preach to people for years. There's no magic approach. There's no one approach. But I want to go back to perfection because I read 92% of people give up on diets in the first week because they weren't perfect in their mind. They thought they messed up. And I think a lot of that has to do with, they create these labels in their head. They put categories of food. Oh, that's healthy, unhealthy, good, bad. And I try to advise, look, foods are none of those things. Foods are not healthy. You can't eat an apple and then you're healthy.
Exactly. Yeah.
Food's either nutrient rich or it's not. And if you're
Right.
eating 85, 90% of your diet's nutrient rich foods, whole foods, and 10% is some things that we might label as bad, you're going to be in good shape. But there's so much, there's a lot of psychology, as you know, that goes into that and those habits. And that's a whole different discussion for another day to
Right.
help people figure that out. And that's
Right.
where, when using these type of drugs and getting off, they should be referred to a dietitian or a nutrition professional that they can sit down with and talk about. Not someone who's just going to give them a meal plan, but coach them on how to change their behavior. So I love how you mentioned all that. That's so critical. All right. Last two questions. I've heard from people who mentioned they haven't lost much or any weight using this drug. So could someone be a non-responder, or are they just not watching their diet well enough?
So could you be a non-responder? Potentially. So GLP-1 is a naturally occurring hormone in our body. So I would think most people would respond to it in some degree. But again, like we said at the beginning, there's no magic behind the scenes on what's causing the weight loss. So if you take this and you don't have a decrease in appetite and you are still just taking in as many calories as before, and not eating, again, nutrient dense food, like you said, yeah, I can see somebody not losing weight.
Great points. Are there any areas or topics we didn't discuss that you feel like is important and our listeners need to know about?
I think the main one to keep in mind is that, any type of weight loss medication is a tool, and that is it. It has to be done in a framework of understanding nutrition. And you don't need to go as far as, I'm sure, your level of knowledge. But people do need to understand nutrient dense food, calorie dense food, portion size, things like that. It's a tool, and it needs to have like, I prefer to use the term nutritional strategy. People should have a nutrition strategy on how they're going to accomplish whatever their goals are, whether it's weight loss, weight gain, performance, etc. Have a strategy, have a plan to get there. That type of tactic works better than just, I'm going to take this for a little while, lose some weight, and then we'll see what happens.
Excellent. Love it. Well, Doc, thank you so much. This was fantastic. Now, we're not done with you yet because
Okay.
We have what's called our curveball round. We're not even going to talk anything about what we just talked about. It's going to be obviously 3 questions I'm going to throw at you that are fun. Okay. The first question, as people know, is I'm going to always ask this question first because my love of music is just probably, besides sports, they're probably equal 1 and 1, 1 and 1A. I love them both kind of the same. So my question to every guest is, if you could be the lead singer of any band, either today or they were in the past, who would that be?
Oh man, that's a great question. Oh wow. Okay. So I'm going to have to go with first thing that came to mind. I'll have to go with Van Halen.
Wow. Nice. So you're an 80s or
I'm an 80s guy. I'm in my mid 50s. I'm an 80s guy. So I'd have to go with Van Halen.
Now,
I don't think I could survive that lifestyle for very long.
So I guess a question on that is it David Lee Roth or Hagar?
Ooh, Dave, I'm going to go with David Lee Roth.
Okay.
I'll go with David Lee Roth.
Next question. Now this one I just kind of threw out there because it's different. If you as a physician, if you can invent one medicine that can change the world, what would that be?
Ooh, wow. That is a great one. Okay. So which area to go to?
It's tough. Like this one, I'm thinking I don't know either, because I think, and I won't say what my thoughts would be, but there's so many options that could cure or fix a lot of problems, right?
So atherosclerotic cardiovascular disease, still the #1 killer worldwide. So I would go with, and since I get to just wish it into existence, I would go with something that improves HDL function, since we've been unsuccessful with that so far from a pharmacologic point of view. We're doing better with handling ApoB, which is our biggest risk factor for heart disease. So I'm going to go with a medication that improves HDL function. How's that? That's pretty esoteric, but
that's pretty specific. I love it. Yeah, and for those that are listening, get your ApoB levels tested. Right. I got mine tested; it was high, and it was like, wow, thought I was doing great. And yeah, obviously, we're treating that. So I'm glad you mentioned that. Last question: something unique about you that only very few people know.
Oh man,
non-related to your career.
Another toughie. Something unique about me. Oh my God.
I'll give you mine. I sang in a 90s alternative cover band. A lot of my close friends are the only people that know that, or family. None of my colleagues, unless I mentioned it.
That's great. That's a good one. Oh, so okay. All right. So when you say that again, the first thing that came to my mind was I used to do stand-up magic as a hobby. Never performed, but I always liked close-up magic, sleight of hand. I always was fascinated by that. So used to do that just kind of as a hobby.
Awesome. That's fantastic. That's really cool. Doc, thank you so much. This is fantastic information. I know our listeners really enjoyed the information they learned today, and hopefully they can put a lot of that into practice. And for those that are, have taken the medicine, considering it, continue to work on your habits, find a professional that can help you to change your behavior and continue a good life and to live a long, healthy lifespan. So Doc, thank you so much for the time today. This was fantastic.
Absolutely. Happy to be here. Thank you for having me. I appreciate it.
And we'll talk about having you on for a different topic, maybe in the future.
Absolutely. I would love to.
Have a wonderful day.
You too.
Well, that's it for today's show. Thanks for listening to the All Me podcast from the Taylor Hooten Foundation, a nonprofit organization leading a national campaign to enlighten people to the truths about appearance and performance-enhancing substances and inspiring people to live and compete without the use of these substances. Please be sure to subscribe to our podcast and tune in to our next episode.